And we're back. This video discussion is going to be about sympathomimetic drugs of abuse, corresponding to two chapters in Goldfrank's Toxicologic Emergencies. Chapter 73 on amphetamines and Chapter 75 about cocaine. The learning objectives for this session are that you'll be able to list the expected clinical effects of sympathomimetic drug toxicity, describe both the similarities and the differences between the mechanisms of action of cocaine and the amphetamines, and to outline a treatment plan for toxicity from these drugs. Even though these topics are split into separate chapters in the textbook, the clinical effects and treatment approaches are very similar, so they're being considered together for our purposes. These are sympathomimetic drugs and can result in signs and symptoms of a sympathomimetic toxidrome. Some of the hallmark features are an increased heart rate, increased blood pressure, the skin can be sweaty, also called diaphoretic, and there can be varying degrees of CNS excitation. Initially, a euphoria, which is what the drug user is typically seeking, but with more toxic effects can manifest as anxiety and agitation, which may have gotten bad enough to prompt a person to reach medical care. The most serious complications include CNS excitation so severe it results in seizures. There can be various cardiac arrhythmias, typically tachyarrhythmias, myocardial ischemia, stroke, and hyperthermia. Let's take a look first at cocaine. Cocaine is a tropane alkaloid that's extracted from Erythroxylum coca, a plant native to South America. And if we look at cocaine's chemical structure, we see that it's a tropane alkaloid, which is more structurally similar to atropine than it is to the amphetamines, which we'll be looking at next. But despite this structural similarity, the clinical effects of cocaine are distinctly different from atropine, which causes anticholinergic effects, a different toxidrome from cocaine's sympathomimetic effects. And in contrast, here's the structure of amphetamine. The word amphetamine is a contraction of the longer chemical name alpha-methylphenethylamine, and you'll see all parts of that name surrounding the structure of the specific drug, amphetamine. But the word amphetamine is also used to indicate the entire drug class of psychoactive phenylethylamine derivatives. And here in the lower right, we see the similarity in structure between amphetamine and our endogenous catecholamines such as epinephrine. Since the amphetamines look so much like catecholamines, we might expect them to have a sympathomimetic effect, and they do. But this isn't because they bind directly to adrenergic receptors themselves, as we'll see very soon. Instead, they are indirect sympathomimetics, which increase the synaptic levels of our endogenous catecholamines, augmenting their effect. Part of the mechanisms of action are shared by cocaine and the amphetamines in that they block neuronal biogenic amine reuptake. The figure here shows a presynaptic sympathetic neuron in purple with vesicles containing norepinephrine. This gets released into the synapse, it binds adrenergic receptors on the green postsynaptic membrane, and the signal is turned off when the norepinephrine is reuptaken into the presynaptic nerve terminal. And this reuptake channel is shown here being blocked by cocaine. This is the primary mechanism of action of cocaine, and while it does occur too with the amphetamines, it's typically a minor contributor there, except in cases of quite severe amphetamine toxicity. With regard to additional mechanisms that are unique to each class, cocaine also blocks fast sodium channels. In fact, cocaine was the first local anesthetic, used because it blocks neuronal sodium channels and therefore blocking the perception of pain. With relatively severe cocaine toxicity, we can also see the sodium channel blockade effect on the heart, as demonstrated in the EKG here, showing a wide complex tachycardia, wide because sodium is blocked, and the characteristic positive R wave in AVR. The primary way that amphetamines work as sympathomimetics is that they enter the presynaptic sympathetic neurons, in this figure shown as dopaminergic neurons, and they interfere with and prevent normal dopamine reuptake. Amphetamine in the cell can induce reverse transport of dopamine out of the sympathetic neurons rather than in. And since amphetamine's chemical structure is so similar to the endogenous catecholamines, it is pumped into the presynaptic storage vesicles where it impairs the concentration of dopamine and norepinephrine, which raises their cytoplasmic concentrations, further impairing their reuptake from the synapse because that is dependent on cytoplasmic levels remaining low. So, from this we can get a sympathomimetic toxidrome. How do we treat that? Here's a simplified description of what's going on with sympathomimetic toxicity. There's a vicious cycle going on in the purple boxes where CNS excitation causes increased neuronal firing, and because there is reuptake blockade, we see an exaggerated sympathetic response, which in turn leads to even more CNS excitation. This is typically treated with benzodiazepines to block or at least to attenuate this cycle. And you treat the complications such as seizures, hyperthermia, tachyarrhythmias, and myocardial ischemia if and when they occur. Another reasonably frequent complication to look for is rhabdomyolysis, the breakdown of skeletal muscle. For most patients who present with a sympathomimetic toxidrome to the emergency department, and for all of them who are hyperthermic, I will be ordering a serum creatine phosphokinase, or CPK level, to check for rhabdo. Patients with rhabdo are at risk for developing kidney injury and are treated with IV fluids and sodium bicarbonate. Yes, yet another tox-related indication for bicarb. And this ends my general comments about sympathomimetic drug toxicity and the approach to its treatment. For the remainder of this video, I'm going to briefly cover a few agent-specific items. If you were to go out and buy some cocaine from a drug dealer, what you'd be getting is the hydrochloric acid salt of cocaine. Like all salts, which carry electrical charges, it's going to be relatively more water-soluble. But if you really want to absorb the drug more rapidly through lipid bilayer membranes to get a more intense euphoric effect, then you need to convert the salt into the free base and smoke it, so that you're using the large respiratory surface area rather than just relying on slower absorption through the nasal mucosa, as would occur if you snorted the cocaine salt. So how do you do this? You dissolve some of the salt in water, add lye, sodium hydroxide, to increase the pH, and then apply heat with a flame, as shown here. Next, you add some organic solvent and mix it together. The cocaine salt is converted into the free base, which dissolves better now into the organic phase of the mixture. This is just like using a separatory funnel in the chemistry lab like you might have done for OChem. The next step is to remove the organic solvent to leave just the cocaine free base, so you vaporize off the volatile organic solvent. And here's the potentially dangerous part, because this is usually done by applying heat from a flame again, and most organic solvents are pretty flammable. So be careful not to set yourself on fire at this step. But assuming you don't light yourself on fire, you then smoke the cocaine free base, which volatilizes much better than the cocaine salt, which you'd mostly just be burning up if you tried to smoke it without freebasing it first. And this brings up the subject of crack cocaine. Crack is cocaine that's been pre-freebased for the consumer already, removing that risk of self-immolation on the previous slide. Crack is prepared into crystals of freebase cocaine, but these crystals are far from perfect. They have lots of irregularities and air inclusions, and when you heat it up to smoke it, the crystals will crack, making a notable cracking sound, hence crack. MDMA is a shortened name for 3,4-methylene-dioxymethamphetamine, which is a popular club drug. It's often used as an entactogen because its pro-serotonergic effects can promote euphoria and a desire to socialize, which seems to be the point of using drugs at these venues in the first place. MDMA goes by several street names, and I'll mention just a few here. Some really cute pills can be made from MDMA and are sold and distributed as ecstasy, or just X. The term Molly, meaning molecular MDMA, originally just referred to crystalline MDMA, which might be swallowed, snorted, or placed into a capsule form and then swallowed, but now Molly might refer to MDMA in any form. Now, it's become increasingly recognized among MDMA and other sympathomimetic drug users that partying real hard and dancing for prolonged periods could make you dehydrated, hyperthermic, or result in rhabdomyolysis, so people are cautioned to drink plenty of fluids. And this is a pretty good idea, but MDMA in particular can be associated with significant hyponatremia, a low serum sodium level, potentially causing altered mental status or seizures. And this may be a result both of overzealous fluid intake, but also because MDMA can induce SIADH, the syndrome of inappropriate antidiuretic hormone release, which tells the kidneys to hold on to water more than it holds on to sodium. So you'll probably want to check serum electrolytes on patients requiring medical attention. The so-called bath salts are synthetic cathinone derivatives, and here we can see the close structural similarity between the cathinones and amphetamine. Methamphetamine is currently one of the most widely abused of the amphetamines. One of the reasons for its widespread availability is that it's a pretty simple single chemical step to go from pseudoephedrine, as available in non-prescription congestion medications, to methamphetamine. It's simple enough that people can create makeshift labs in their homes or even in a pickup truck as shown here. So it's an easy way for an enterprising home chemist and drug dealer to turn a profit. But it's also possible to make vast quantities of meth in a super lab. The chemical setup is straightforward, and I've shown all the steps right here if you're into that sort of thing. And lastly, I found these photographs at a website called Faces of Meth. A law enforcement organization in Oregon compiled booking photos of people who had been arrested and who were also meth users, and showed the progression of how they looked over time to demonstrate some of the shocking changes that can occur. Meth and all of the sympathomimetics decrease hunger circuits in the brain, leading to weight loss, although the people spending more of their money on drugs than food is probably also contributing here. And what we can also see here is that some people develop sores, and these are from drug-induced picking behaviors. Patients repeatedly using cocaine or amphetamines can complain of feeling like there's bugs crawling in their skin, and some will report even seeing these bugs and scratching them out, such that the drug-induced tactile illusion can then turn into an actual drug-induced delusion of parasitosis. So, what did we learn, kids? Don't do drugs. Thank you for coming to my TED Talk. I'll be seeing you around.